In 2015, we had 1 million asylum applicants. Of those, 300,000 were children. Of those 300,000, a quarter of them were unaccompanied. So it's a large percentage, and no doubt their health challenges are greater than their peers that are accompanied, and that's what we're going to explore a little bit today. We have a stellar panel to do this. We are going to start, and I will introduce each one of them as we come to them. We're going to start with Dr. Anders Jern. He is a pediatric consultant at Saczka Children's Hospital and a professor of social epidemiology of children and youth at the Center for Health Equity Studies at the Karolinska Institute in Stockholm in Sweden. Anders, why don't you start for us?
Okay, thank you. Well, as Christy said, there are many migrant and refugee children in the world today. UNICEF estimated that there were about 11 million living outside of their country of origin in 2016. The overwhelming majority of these children are not found in Europe, but in the low and middle income countries in Africa and Asia. But in recent years, more and more of these children have also come to Europe. And many of them arrive with accumulated needs of healthcare. Why? Well, because many of them come from countries where the healthcare system has been destroyed and overwhelmed by war, infrastructure destroyed, and because they have gone through a journey full of difficulties and without access to care. And so they arrive with these needs. And what are then these needs? Well, what we can see from the surveys carried out so far is that the most common pressing need of a physical health problem is dental health. Many of these children have a lot of caries. But many also have needs of qualified medical care and rehabilitation because they have chronic disorders or they have disabilities. Some of these need to be diagnosed also after the arrival. Furthermore, these children come from countries in the low and middle income world where chronic infectious disorders are much more prevalent than in Europe. And so these needs to be identified and treated properly. We also know that many of these children lack the basic vaccinations because of the problems with the healthcare system in the countries they come from, as I mentioned. But when we look at the overall picture, and don't try to neglect that there is a considerable burden of physical health problems, there is no doubt that the main problem that we see has to do with psychological well-being and mental health. And why is this? Well, exposure to armed conflict in the country of origin is very common. And with it comes different kinds of psychological trauma. We know that many children have been exploited on the way, and this is to a certain extent a new phenomena that we see from surveys on the way. That very many of the children going through the Sahara, who go through Sudan and other routes, have fared really, really bad on the way until they come here. But then they arrive in our countries and are put in a situation which is in no way without its own stressors. The uncertainty before having received the hopefully yes from the asylum procedures, the daily stresses of meeting a more and more xenophobic general population, and the dire financial situation that most of these families are in. So there is a need for a good public health strategy to promote the psychological well-being of these children. And what should that look like? Well, there should be a family approach because for those who have have families, because we know that parents are the best and most important support persons for these children. But there is also real importance for education, and that includes school, of course, but also preschool. So access to those arenas where children spend their days is really, really important. But there is also some evidence for more targeted interventions, building on psychoeducational theory regarding trauma, culture-sensitive parent support programs, and interventions in the school environment. Thus, there is no question about the healthcare needs of the migrant and refugee children. And there really shouldn't be that much of a question about access, but because we know that all European countries have signed the UN Convention of the Child. And when the founders of this convention, they very much had children like refugees and migrant children in mind when they wrote this convention. And many of the articles there are extremely relevant for migrant children. And already in Article 2, it makes clear that the rights of the children are not only for resident children, but also for children in other circumstances, including asylum seekers and children in an irregular situation. So the first step towards a better health for migrant children in Europe goes through the recognition of nations of the obligations that they have taken on by signing these conventions. All migrant and refugee children, according to the convention, have a right to health care, including primary, preventive, and mental health care. And they also have a right to have education on the same premises as other children in Europe. Thank you.
Thank you very much, Anders. And let me just ask you a couple of follow-up questions, if you would. You spoke to the biggest issue being the mental health issue. You also spoke to some of the interventions that you know can work to help in this area. But going to the UN Convention of the Rights of the Child and the obligation that these children should have the same access to health care as the resident population, how well does all of this come together? Do you see countries starting to connect the dots on this? They have access to health care and some of these interventions that you're speaking of?
Well, we did, within a European project a couple of years ago, a survey where we looked into the policies in the European countries. And what we saw was that there's a handful of countries that actually have a law that makes it clear that all categories of migrant children do have these rights. But that's just a handful. Most countries in Europe actually exclude some categories, often children in an irregular or undocumented situation. So, and some countries also exclude asylum-seeking children from many rights for health care, for example. So there's a lot that could be improved.
Okay. You have a report coming out that you're working on with WHO on child health. If I remember correctly, it's coming out this autumn. Could you speak a little bit about what that is?
Yeah, it's a part of a series of reports that WHO Europe are producing at this time. It will deal with the different health problems that we see in migrant and refugee children, and also give some ideas about how we can address them in a public health perspective. So we give examples of more specific interventions built on psychoeducational and parenting and school platform programs, but also give more general principles how a national and local policy could be designed to try to address this really important aspect of psychological well-being and mental health.
Terrific. Thank you so much. Albertina, let me come to you. Dr. Albertina Ball is a doctor who is a specialist in tropical medicine and hygiene. She worked abroad for 7 years in places like Sri Lanka, Mozambique, Malawi, and Cambodia. She's a pediatrician with this focus in tropical medicine. She says she loves clinical work and emergency care, but we always need that public health approach. And that's how her passion to refugees came about. Albertina.
Thank you for your introduction. Thanks for the invitation. I'm here on behalf of the Dutch Association of Pediatrics.
Is your microphone on?
Oh, yeah, good, thank you.
See, they gave us one job and I failed too.
Thank you. So I'm here on behalf of the Dutch Association of Pediatrics, the working group of international child health. And like my predecessor said, we are confronted with a lot of refugee children in our daily practice. And what we were asking ourselves as pediatricians, like, are we doing the right thing for those children? To give you just an example, when I see a child born in Holland in my consultation room, a child comes in with a fever, enlarged lymph nodes, and this child is born in Holland, I know already a lot about this child without even asking. I know mother has gone through antenatal care, so she received her testing for hepatitis B, for HIV. I know this child has gone through the immunization program, but when I see the same complaints in a child originating, for example, from Syria or North Africa, high fever, enlarged lymph nodes, I don't know anything about the background of this child, and that is the thing we have to we are dealing with. Just to give you some examples, in a group that we know is a vulnerable group, because these children come from countries with unfavorable conditions. Some of the diseases have high prevalences. Then you have the migration process. Their flight might not have, or might have taken a long time. And as well as the unfamiliar surroundings, they are ending up in their reception countries. There's 3 components that those families have to deal with. So, for example, a child ending up in our hospital just 2 weeks ago with a bacterial sepsis. But when we tested the child, it also appeared to have malaria and the schistosomiasis. And we could treat it for that, but it was not a presenting symptom. Or another child presenting with psychosomatic problems. We see that often in our practice, so I agree with you. They come with complaints about being so tired, having a headache, abdominal pain, and often it is plus. It is as well a mental problem, but this child appeared also to have as well latent tuberculosis, and it was a carrier of thalassemia, that is a genetic disorder of the red blood cell, causing anemia. So what are we, then we discuss with ourselves, what can we do about that? So the first step we took is to set up a notification system, to investigate under pediatricians, like what are the things you are dealing with in your daily practice. So we got like a number of reports, and the majority was about the continuity of care. Because many of those children are transferred from one location to the other, and especially children that are vulnerable because of a disease, a complex disease of children with a disability, involving many health professionals, the continuity of care is endangered. The next thing that was reported by pediatricians was this unknown medical background. We don't know their history. And the third thing related to this is the health handovers. So information gets lost according in the line. So then we saw the need to come together and make a multidisciplinary group. And now at national level, we are going to develop a multidisciplinary guideline. And our stakeholders involve as well pediatricians, but also public health doctors, the youth health doctors, microbiologists, but also the psychiatrists. Syrian doctors are there, so the stakeholders from the refugee population, and, for example, people from the Central Organization of Asylum Seekers. And the schools as well. The people involved in the language school for those children. So we try to come up with multidisciplinary guideline at the different levels that a child will present. The third thing I want to talk about is that we are at the moment talking with the Ministry of Health to do a pilot involving as well pediatricians plus youth health doctors, so the public health together with the curative services. In Holland, this system works very well. We have a very good developed public health system where all those children are seen to improve the health assessment upon entry, as well a medical test, and also those psychological and mental health issues are being addressed. So coming back to our question, are we doing the right thing for those children? I think we are trying, and that's those children are that we move on from public health an overall approach to the child-centered approach, that we come up with a tailored program for them. And that's all I think I want to tell you. Thank you.
Thank you so much. I'm on. Thank you so much. Let me ask you just one question about your multidisciplinary guideline that you anticipate coming out. When will that be ready, do you think?
Yeah, we plan to do that in 2 years' time. Okay. Because it takes time, because you want to involve, we can come up with a guideline in 1 month, but then we did not involve all these stakeholders. So we want to take our time, and especially that when we have that we make the connection with the other stakeholders, and that we create the chain of care for those children. And not only at one level, not the pediatric care, no. We need to work together. So it will probably take 2 years.
Speaks to what you were saying about the continuity, doesn't it? All right, Albertina, thank you very much for your time.
Thank you.
I'm going to switch now to Dr. Ketil Aida. He has a PhD in sociology and works as associate professor in social work at the Department of Health, Social and Welfare Studies at the University of Southeastern Norway. His research has primarily focused on childhood and migration, the well-being of unaccompanied refugee minors, and social work with family and children with a minority background. Let me turn it over to you.
Thank you. First of all, thank you for inviting me to this seminar on these issues of refugee and migrant children. I will, in my presentation, talk about unaccompanied minors, which is a vulnerable group of children, a special vulnerable group, because of their background as during the flight and the resettlement in a host country. But at the same time, they are resourceful in many ways. They have inspirations, and they have often often capable to develop positive view of their future and so on. So in many ways, when I'm a researcher on this issue, a lot of research is about vulnerability, and the resourcefulness is often forgotten in a lot of research. Understandable, because there is no doubt that these children have mental problems, and they even have more, and they have less or poor mental health than other group of refugees in general, and also compared to majority children. And according to the UN Convention, the states have a responsibility to protect these children, and especially they have to make sure that they have a good care situation in different countries. And interesting is that there are different regimes and practices in all over Europe connected to how these practices is done, and there is what is the responsible for the state, what is responsible for the local, regional authorities, how foster care is used in some countries as a dominant practice. In other countries, like in Norway, residential care are the preferred practice. and how shall we look at the majority placement or minority placement? There are different levels, and who others is it? Is it the migration authorities, or is it the child welfare authorities? Also different in different countries. And I suppose so it has to be. But connected to health statuses, as I told, there are a lot of complicated issues connected why it's so, and some factors is, of course, trauma, what has been experienced before they arrived in the host country, but also the condition in a receiving country is a part of explanation why the mental health is important to look at. And of course, social connections in a new country is more or less most of the most important issues when a child is coming from other countries. And in my research, I have special interest in how trust is connected to how these children have to develop. And that is a part of looking at a trust as a resourceful way of doing social connections. And when I have a research now about trust and how they are able to develop what we call judgment of trustworthiness of people and institutions, and it's very important in care situations in countries, different countries. So I think that is a very good way to look at how these children are able to reflect on aspirations, how they trust people like peers, how they manage school, the school system, how school are. It's difficult to meet children like this, which is tremendously diversity of backgrounds. Some are good educated, some have no schools, and so on. So it's difficult to handle in many ways. So I think for me, I don't know if it's for other, but I think trust and trustworthiness is a very nice or good way of looking at these children. Just once more about how to provide health care and that's a good view that these children, some of them have no support in caring. Others have support, and there is some research that tells that children that have support in caring are more provided for health care. So that is also very just like having parents that help you to find the way to a healthcare system. So that is also important when it comes to support. Yeah.
Can you scratch the surface on this just a little bit for me? I'm kind of hoping you can elaborate a little bit more and maybe tell us, because I know your work is quite specific, and if you could tell us some of the specific situations that you see in unaccompanied minors compared to what you see in other children and young people.
Yeah, and it's obvious. One of them is, of course, they are without support of parents and families, and this is, of course, special. And they are, in many ways, reflecting on how they will avoid loneliness in the situation, and therefore, trust is very important to reflect who can I trust, and especially the group they are talking mostly about is peers, not caregivers, or the peers are the most important for them. And I have some interviews where they are really good in reflecting on how can they trust their peers in the situation, and I think that will be a part of the care as a system to reflect on how can a care situation be trustworthy for these children, because a lot of these children also talk about distrust as connected to caregivers, because the caregivers are from 8 to 4 and 4 to 10, and so they can never trust if this person is trustworthy for me as a person. It's not like a mother or a father. It's so how can you make an institution that can handle such issues that they are reflecting on? And I think it's too less discussion of that kind of issues.
It was one of the. I was intrigued by the trust findings that you had, and it was one of the questions I was, kind of mulling with in my head: is how easy is it for this group of people to trust, given what they have been through themselves? Yeah. All right.
It's just like when we are living in a country like in Scandinavia, for instance, we don't talk about trust. Yeah. We don't have to think about trust because we take it for granted. But these children are coming to a society where they have to build up trust. Yeah. And why not know that? Because when we are talking about trust, it's immediately distrust, because then we have to think about it. So, and these children have to start the rebuilding of how to connect to how and why they should trust a system of social institutions or whatever, or people they will trust or not trust. Yeah.
Thank you very much, Kettle. Appreciate it. I'm going to go ahead and open up the floor. You can leave your microphone on, Kettle, because we're going to go to broader questions. I'm going to go ahead and open up the floor to questions for all of you online in the room. And I want to just remind anybody that joined us late how you can do that. If you're watching this on your computer, scroll down just a little bit below this window and you can enter your question there. Obviously in the room, you know what to do. If you are on a mobile phone, download the app Slido, S-L-I-D-O. You'll need the event code, #KHHM for Knowledge Hub on the health of migrants. And then you can enter your question there. You will also see a place that you can answer some survey questions, and we'll do that in a minute. We have microphones in the room. One other thing you can do, remember, is to vote for different questions. You see a thumbs up sign next to the questions as they're coming in. If you click on that, then it will push it further up the queue, and what you see here is the questions that are most in demand. I will take 3 questions at a time, just so we can cover as many questions as possible. And then we will turn those over to the panelists, let them pick the relevant parts for their research, and then we'll do it all again. You want to start?
Yes, thanks, Pino Annunziato from the Migration and Health Department here in WHO Euro. Just a small comment on what Albertine said, and then a couple of questions, very quickly. The comment is, you mentioned the continuity of care, which is disrupted during the journey for several reasons. I will tell my comment is that it's disrupted even in the final destination country, unfortunately.
Yes.
We saw this in several countries, that because those people are moved from one center to another, from one institution to another, and the communication, even in well-developed country, sometimes is missing. So this is just one comment. Then the 2 quick questions. One is regarding the age assessment. Which kind of methods are used in your country to define the age, to assess the age of the children? Because this is extremely important in terms of the legal framework. If they are children, they have a different legal framework than if they are adults. So how do you check the age of those children in your country? And then the second one, you mentioned everything regarding mental health, which is clearly a priority. There are some language and cultural barriers that are particularly important in the mental health field. How do you overcome this?
All right, thanks, Pina. All All right, his question comes in two parts. I'm going to slip two more questions
maybe you
in
can answer that
from
one.
the
Yeah.
online audience. One is, how do we ensure that children arriving to Europe are fully vaccinated, especially as immunization programs could work differently in countries that they come from? And the second one, screening, personalized assessment, or no screening, including communicable and non-communicable diseases.
Shall I start that one?
You shall start that one.
So I think I talk about the situation in Holland. So all the children are, again, the records are taken from the caretakers, and then the vaccination is done. So it's not, there is no assessment before that, but there is no need for that, because if you do a double vaccination, is okay. Screening, personalized assessment, or no screening, it depends on the policy in the European countries, and I think there are several policies. And what we are working towards is a tailored health assessment, tailored according to the country of origin. If you come from Syria, there is no need for testing for HIV or hepatitis B because it's hardly there. But if you come from sub-Saharan Africa, that might be very different because those infectious diseases have very different prevalences, so pre-existing conditions. So that's...
Should I pick up? Yeah, we did a survey of how this is carried out in the European countries a year ago within a EU-funded project. And what we saw was that there are quite clear patterns, there are differences. In Eastern Europe, this is infectious screening, it's often mandatory, while in the northwestern countries, Scandinavia, and UK and the Netherlands, it's much more of an individualized health assessment. In Italy and Spain, there are no screening programs, were not at that time anyway, because it was not because of lack of resources, but more a stand that it was not necessary, as I understood it. My view here is that because of something that we haven't mentioned yet, but the heterogeneity within the refugee population, this has to be an individualized health assessment. If we really want to do this to be in favor of the children, and there has to be an opening for picking up all different kinds of problems, because although some problems are not very common, there will be children with diabetes, or there will be children with leukemia. At least I've had those children. And we need to have a way of doing this that can pick up the very different needs of the children, I think. And I think definitely that there is many countries in Europe that could use the resources that they're already putting into these very static screening into a more individualized system, and that would be better for them, and it would also be better for the children.
Ketil, did you want to add anything to this?
No.
Okay, very good. Do we have any other questions in the room? All right, I'm going to jump to the online questions. How do we, oops, that one's already been asked. Are European countries still detaining children, and what impact does this have on mental well-being? I think that goes to what you all were talking about, the mental challenges, the mental well-being. That is such a big problem for these children, obviously a component. Let's see, what kind of professionals or specialists do you think are missing in our panorama right now, specifically speaking about public health problems and refugees?
I could pick up on the detention, because it is a fact that many European countries today detain children when they're in the situation of deportation. And this includes my own country, and my government in Sweden recently said that they're going to double the number of detention centers where also children will be detained. So this is an important question, and the European Council and several of the main child rights organizations picked up on this, that this is a real problem and it's something that needs to be dealt with.
I was wondering if we have any more specifics on that, if I can just add a follow-up question to that, to the impact, I guess, of some of the detainment
Well, it will be. There are different ways of detaining children, lighter and more rough, you could say. So it will depend a lot about the period, how long, the duration that they will be in detention, but also what possibilities they will have of education, of having play facilities, recreational facilities, etc. How the staff will treat them. So it's difficult to say anything in general like that, but the general experience, and although the research is certainly hasn't been much covered by research, is that it, of course, is a major problem for mental well-being or being detained for a child.
Yeah, and on top of that, the continuously transferring those children, the effect on mental health, there's also some research on this. Every time a child is again referred to another asylum seeker centers, what is this doing with their mental health? And I think also with that trust in the system.
And of course, this is also a very political question, how to deal with these children, and it have effects on how to these children. We don't want to talk about it, but it's still the case that you can see that the main reason is how can we in the history they said it directly. We want to get rid of these children because we don't want to have them here. So, but now we're using more human talk about how they are treated, and we use other ways of talking about the children. But of course, it's very important, connected to mental well-being, to handle these issues in a proper way. It's.
Kettle, I had a specific question for you, actually playing off of what you just said and what you were saying earlier, and that is going back to the issue of trust. It's incredibly hard to build trust. It takes a long time. Are there any best practices that you've seen or heard about that can expedite this problem in some of the different institutions that the children will be interacting with?
I'm not sure. Yeah. Because, but I think there are a lot of good practice in different institutions, but it's mostly focused on the personal relation and the personal trust, and that is the basic way of doing it. But it's not enough in an institution. You have to connect to the society, so you need to make social connections. And asking the children how they manage these social connections related to different groups of people. So social networking is a very important issue in this, and not in institutions. Absolutely, very important.
Let's go to that second question, which was what kind of professionals or specialists do you think are missing in our panorama right now, specifically speaking about public health problems and refugees? Does anyone want to take a stab at this? Anders looks eager.
Well, I don't think that it is specialists that we primarily need when we talk about public health problems and refugees. What we need is primarily school and primary care. The basics. There is also a need for some children to have a more advanced kind of, for example, psychotherapy or so. But that's not where we will take care of the big load of public health problems. That has to be taken care of in the environments where these children are every day. So we need better knowledge for people working in those sectors, in teachers, primary care physicians, nurses, and so forth. And then it's good to have specialists that can take care of the unusual infectious disorders and so forth. And that can have psychotherapy for the children who are mostly in distress. But it's not them who will be spearheading the public health efforts for these children.
Remember, if you have any questions, you can just put them in the question box. You can also vote for the questions that you are most interested in. Albertina, did you have anything you wanted to feed into that last question? You looked like you wanted to say something, and I didn't want to walk away from you on that.
Yeah, I think the good thing with the public health, at least in Holland, it's a very strong system, and it's an existing system, and they have access to all of those children, like the schools. So I agree with Anders, that you look for the institutions that have trust, they have access to see where are the problems and to filter out the children that need help, that you focus on the needs of the child. And preferably at the lower level, and make it not a problem, but how do you say, you make it normal, you normalize
it.
Coming from, of course we see all problems, but you want to give these children a good future, because that's what we all see. We know the majority of the children that are entering now, they will be granted residency, so you want to have them a good future in their yeah. I don't know if that's an answer to this question, but...
I just have an example from my research interviewing an Eritrean boy, which is quite a normal or easy example, but it is, I was asking him, and we were talking about why he was not coming to school, and he was a part of dropout in school, and I asked him, why don't you go to school in the morning? And he told me that in his home country, his family was waking her up, make his food in the morning and the food for the lunch, and this was difficult when he was in Norway and had no one around him. He was not in a supportive care situation. It's a very simple example, but it is more than a practical level. It is emotional, and it's also a kind of meaning. And he had tears in his eyes when he was telling it. It's a simple way of telling that the everyday life is mostly the most important situation for a lot of these children.
Like you were saying, it normalizes, quote unquote, normalizes things a little bit more. Any other questions from the room at this point? Yes.
Hi, I might also use the mic because I have the mic.
It's your prerogative.
My name is Suraj. I work with the Migrant Health Program here at WHO. Just to touch upon what you guys were discussing right now, the public health approach, when we look at what the clinicians are facing, it's mostly when the system sort of fails, when the larger society fails. And part of the issue, how to address might be through education and other things. But it also quite is multi-sectoral. So when we look at from a public health point of view, are there sort of bullet points, not necessarily best practice, something you could, if there is a policymaker listening to this particular conversation webinar, are there key points you would like to highlight? Maybe these are the few things you should have in mind when addressing the health, as the WHO definition, health of children, including unaccompanied minors as well. Thank you.
Joseph, do we have any other questions online? I think we've worked our way through these that we want to add in. There we go. Any concrete examples of psychoeducational interventions that you can suggest? We are planning to implement a psychoeducational project for unaccompanied minors. Any suggestions? That's your second question. Anders looks ready for it already. Yeah. The third question will be how to protect children along migratory routes. Mental health and abuse are issues there. Reception conditions, I think we've started on this conversation, but it's good that there's interest to go deeper. And status determination procedures exacerbate distress. Anders, we'll let you start.
Okay, so I will, in the report that you are all anxiously waiting for, that will be published in the fall, I pick up on one psychoeducational intervention that has been used a lot in refugee settings out in the field, so to speak, in Lebanon, in Turkey, for example, and it's called the Teaching Recovery Techniques. In Scandinavia at the moment, this is a technique that is being used a lot in Uppsala by a team there, and they have evaluated it, and it was found to have pretty good evidence. It helps particularly, they've used it particularly for unaccompanied minors. It helps them to handle the traumatic memories that they may have, and it also strengthens pair relations. So that's the psychoeducational intervention I would suggest. And so if you need to find a connection there, the principal investigator in that intervention study that they are doing is Anna Sarkadi, who is a professor of social medicine in Uppsala. So I would advise you to reach out to her. I'm sure she would be interested in a collaboration.
Albertina?
And how will these children be picked out? Is it you are offering that in general, or it will be a specific group of children that will be targeted?
They have actually reached out to the homes that the residential care units in the Uppsala region, and asking the people working there for children who could need this kind of. So it's a kind of a semi-targeted where the people in the homes reach out to the children they think might
need
yeah,
that.
so it would be kind of a secondary preventive intervention in that respect. Yeah.
Anyone else want to tackle any of those three questions?
I could pick up on Zoe's question about the multisectorial one, which is also will be addressed in this.
Well, and the other question there you'll love too.
So I think that we need that the multisectorial approach needs to include a strong family focus, which means that, for example, that parents of refugee children, those who have parents, which is still 80% of the refugee children that have come in recent years, they should be offered psychiatric care when they need to, because we see that poor mental health in parents is a real obstacle for good parenting in this situation. And other ways of supporting their parents, or these parents, in the way so that they can facilitate the adjustment of their children. And there are some programs out there, and I'm not going to mention again where you will find some of this information, but there has been these kind of methods, more systematic approaches used. So that's one important step. The second important step, I think, is to create a good social network, as Ketil already mentioned, around the families and the children. And the third, of course, is to look at the contextual level and to see that national policy regarding migration, for example, should have a health promotion focus, which would include, for example, allowing family reunification so that children can have their parents.
I think if you connect it to care situation, there are some intervention called trauma-informed care, which is about regulation of feelings connected to traumas. And there are also more development supportive care, which is also a kind of intervention. And these are also connected to parents' guidings in where you, I don't know if you know about one program called International Child Development Program, which is used in many contexts in abroad and also in minority groups in Norway, for instance, and these are connected to emotional and cognitive and regulations issue, which is, of course, difficult for parents in exile to understand how these are. It's not a program where you treat parents to do a better job as parents, but reflecting on these issues that is important in a new context and also connected to cultural differences in parenting, for instance. So there are some programs.
There is a third question up there that we haven't really scratched the surface on, and I'm not sure how much experience we have at the table on it, but I'm open to ideas. How do we protect, or how could we protect children along migratory routes? Mental health and abuses are issues. Anyone want to say a few words on that, or is it outside our realm of expertise here?
Can I start?
Yes, please.
I think it is about closing your eyes. We don't see it because this is political, again, issues connected to different countries where these children arrive, and at the moment I think it's NGOs working on these issues, and no state is there for
That's the
the
gap
children.
area.
Yeah.
Yep.
Yeah.
Opportunity, do you want to say anything on that?
Yeah. So when a child turns 18, you when they are under 18, they have a lot of rights. They are under the child rights, have the access to health, to education, and for some of the children, you know already that they are going to be as undocumented refugees. They will, because they know already they are going not to be granted permission to stay. So I think this is a group of children that you already know, for example, what will happen. And I think that there is a need for a transition period for these children. So I don't know if many other people see the same problem. So when you are under 18 as an unaccompanied minor, you have a lot of rights, but then there is a sudden change.
There's a sudden change.
And then a lot of those children get lost in the system. Well, actually, some of them are still real children that needs our protection. And I think when you work with those groups, you know which children, especially Afghan children who will send back. They know. Yeah. No, anyway, it's open to the other people to react.
Anders, jump in.
Yeah, I think you're raising a really important point, which also has a bearing on the question about age assessment, because the reason for why these practices that many of us question regarding how age is assessed in different countries in Europe is the fact that there is such a sharp difference between if you're under 18 or if you're above 18. And we know, when we're talking about the unaccompanied minors and look at the statistics, we know that 80 to 85% of these children are in the age 15 to 17. And what is it that happens the day that you turn 18? And I think that for those of us who are old enough to have children ourselves in this age would not like to send our kids out when they're 18 and being able to handle all by themselves in this very difficult situation. So I think one solution, which is probably completely politically impossible at the moment, for the age assessment thing, would be to have a more gradual handling of young people.
Yeah.
So that it's not this sharp age, but rather a more individually based, needs-based support system. I don't know what you say, Ketil.
Yeah, because administrative, it's a chronological age and not what we can call a development age. So it's you can, and it has connected to rights. It's had connected to economy. And so on. In Norway, for instance, there is an age of 15 when you are under 15 years in the receiving period. They are under the child welfare system, and when you are 15, they are immediately transported to the migration authorities. So age is a very important issue connected to these children. And it has to do with rights and so on. Yeah.
Any questions in the room? Yes, two over here. Microphones are coming your way.
Hi, thank you. I wanted to make a kind of comparison, really, between another webinar that we ran a month ago, where we looked at arts and health. And I don't know if anybody in the room saw that, but essentially that was a look at some of the evidence base behind this increasing interest in using arts-based therapies for health, both physical but also mental health. And the emphasis in the webinar was really more, in kind of run-of-the-mill health systems in Europe. But it strikes me that particularly here in the relation to unaccompanied minors, there might be quite a lot of benefit and traction from using these kinds of arts and health approaches, particularly in arenas of mental health. So I'm wondering whether, you might not be experts on this topic, so I completely understand, but I would wonder if you have any experience of those types of arts and health therapies in these settings, and whether they're, how useful they've been, or whether there's any evidence base behind them, any kind of comments at all. Thank you.
I'm going to throw one more into that. Yes, did you have a separate question? Yeah. Oh, great.
Yeah, so hi, my name is Åsa Nylén, and I'm a technical officer here at WHO in gender and human rights. And my question relates more to gender. We've been discussing rights, but more to gender, because what we know, we're talking about children and youth, but what we know, especially when it comes to unaccompanied children, is that it's mostly boys, right? And maybe the reason why they leave their countries also has to do with gender norms and roles that these boys have. They're the person who is supposed to go to Europe and bring back money or save families. So I'm wondering also, in your experience and in your interventions, if you have any, if you've seen any specific risks relating to gender norms and roles, or needs in in the work that you do, that you have to take specific attention to the fact that this is boys and they come and they have a certain role to play. That's me.
I'm going to add one more question to that, and that is for Ketil. Thank you, Ketil, for the interesting talk. How to overcome distrust in unaccompanied children in healthcare institutions and providers. Any example of work? Do you want to start there, and then we'll come back to the other two?
It's difficult to I think there are no intervention connected to trust, as far as I know. But of course, I think it's for me it's a combination of personal trust connected to trust that connected to an institution as a system, and both has to be in place. It's not enough in a care in a residential care to take the personal trust between caregivers and because they are vulnerable relations and private in many ways, so they have to be over view of how these institutions are able to be trustworthy. And there are two ways of doing that, and that is, first of all, competence. You have to have competence of doing your professional work as caregivers. And the other one is, of course, the institution should be all in the best of the interest of the child, meaning that how can you trust people working there? So there are no, as far as I know, no intervention, but I think when an institution asks the question, how can we be trustworthy so that our minors can give trust? So trust-giving position is nobody talking about. So how can an institution be trustworthy? It's a good question to start.
And that consistency of it, so that it continues happening over time, I guess, so that trust grows.
Yeah.
Who wants to handle the other questions we have? Gender, art?
I could give a first response to the question about art. In the mid-1990s, in my country, Sweden, received a large group of refugees from the wars in Yugoslavia, the former Yugoslavia. And the child psychiatry was more or less overwhelmed by the great numbers of children that were in need of care. And what was developed as a response to that need was a kind of a format based on art therapy, 8 sessions, and was found to be successful in the way that you found that these kinds of methods were successful in the 90s, which means that there was no rigorous evaluation before, after, or anything like that. But that form existed and is described in a book that I edited. But in Canada, they've been working with that. Cécile Rousseau is a creative psychologist and therapist in Montreal, who has written quite a bit about this. So anyone interested in this, I look her up, I think would be a good idea.
Anyone want to tackle gender?
I can talk about it.
Yeah, go on.
There are different reasons why there are boys that are coming, but the interesting here is, yes, a lot of these guys are talking about their relation and loyalty to their parents, and they are talking about a feeling of giving support from their country where they are, and one of the consequences is that they, in many ways, prefer work instead of education. I think that is the most visible consequence of this question, and they tell stories that this family don't ask for money, but this is just a feeling that they are poor, they are not able to do their everyday, especially when they are undocumented refugees in Iran, for instance, from Afghanistan. Of course, you are taking care of that family situation, and it's a pity that the consequence is that I think many just want to start working because of money transfer in some ways. So, yeah.
Want to take anything?
Yeah, I know from some research done in Germany on unaccompanied minors and then mainly men, and the health risks in these groups are really bigger than in young children, for example, but it also has to do with the countries of origin. I know in the Netherlands, like if you talk about unaccompanied minors, their countries of origins is not the same like if they come as a family. So we see more unaccompanied minors from Northern African countries. And then also they come from countries where some of them never went to school. So it really depends on the situation where they come from, but we think they have higher health risks and maybe more health needs.
Just a final comment about gender, which is an important and somewhat neglected issue, I think, when we talk about migrant children. In residential care, gender is an important issue generally, which is relevant here as well, that the way you mix boys and girls in residential settings is often in a situation where there are many boys and a few girls, and that sometimes in this situation that the girls are put at danger, or at least exposed in a way that can be really difficult. So I know one way of solving it, and that they do in some municipalities in Sweden, for example, is that the fewer girls that unaccompanied are more often offered foster care than residential care because of this. Yeah.
And also the way mental health issues are presented very different. What we have seen is that unaccompanied minors, females, often tend to be more in the depression or withdrawal instead of the acting out problems. So it's sometimes more difficult to see what's actually going on.
Thank you. Any questions in the room? Okay. Question up here. Do you have any recommendations? And I think, Anders, I think it was you that mentioned about the parents or the mothers and the mental health among parents. Do you have any recommendations or strategies for screening for mental health among young adults? I'm going to add one more to that. Which research institution has an established reputation on research on children and migration and health? Looking for places to get even more information on that. Who wants to start?
Yeah. Well, I mean, I guess the institutions that the three of us are should be, but I mean, there's an interesting program around migrant children and well-being at the University of Sussex in the UK, I think. In Denmark, there is MESO at the Department of Social Medicine at the University of Copenhagen, which has a long experience and a broad program regarding migrant children. That would be the ones I would think about.
And you have Karolinska.
Yeah.
Any other?
And of course, in the Netherlands, I think you have Faros, don't you? Which is an interesting institution with a long history of working with migrant children.
Yes, and they are very much into cultural issues. That was also mentioned, that we really, they educate also health professionals. It's a good institution, so we work together with them also for the guideline development.
And I thought I saw a question somewhere on the cultural issues, but maybe I did not. Does anyone want to take up the mental health in young adults?
I can give a more general comment, that I think that screening, if we're talking about screening as a screening that as a concept of screening in public health, which means that we want to identify certain individuals and then not identify other individuals, I think that this is an area where screening is not really a suitable method. A better idea is to provide care for those who are themselves seeking care or are found in their daily environment to have need of psychiatric care. And so what we need, I think, instead of screening is rather a psychiatry which becomes more culturally sensitive and more outreaching to migrant groups.
Let me just add this top one in again because they pulled it up for us. The experts have mentioned the need for culturally sensitive services for children. Can you share some good examples of this? That adds into what you've got.
Yeah, and I know from some programs in municipalities in the Netherlands that they identified, we say sleutelpersonen, that means key persons within a certain community, they are sensitive for the problems going on in a community and connect them to the local teams, local public health teams.
Does that work well?
Yeah.
There is an old way of working with this that has been reproduced in many settings around the world, which I don't know where it came from, but it was used in Sweden in the 1970s in child health services, which is the use of something called cultural mediators, which are professional people who have a background in a minority or migrant population, who speaks the language of the population, but are also have been professionally formed in the new country, and so they can serve as a kind of intermediate person to whom can explain things for people like me, who is a native doctor, about how migrant patients express themselves, and they can all. For example, when I used to work with baby clinics in the suburbs of Stockholm, there were people or nurses employed that came twice a week and spent the mornings there, and they had a background in two different kinds of minorities that were common there. They spoke the language of them, and so many parents showed up at those when they knew that they were there, because they knew that way they could get advice by somebody who understands their way of thinking and speak their language. So that kind of cultural mediators have been used in many settings, and I think can be a really good idea. It has its limits because it means that I think in many countries today in Europe we have so many different minorities that it is difficult to have these mediators in every one. But when you have like dominant groups, it's certainly something that can be very useful.
Ketil.
Yes, and you have challenges connected to gender, class, because it's so multi-dimensional in one culture. In Norway, it's a very homogeneous culture, and maybe it's possible in Norway, but not in Afghanistan, for instance. But cultural sensitivity is, for me, a kind of balance between universal approaches to human being and also a special approach connected to culture, and of course the individual unique situation of every individual and family. So there is a combination of these factors when you're talking about cultural sensitivity. I think it's important because we can also focus too much on culture as well, and too little.
Yeah, I agree, certainly. And I think, what you really learn when you're working with people who come from a very different culture is that the importance of culture in yourself, and you also see it in the patients from your same country, because they have if they have a different background, come from other social circumstances and so forth. So I perfectly agree. I think this becomes just much clearer when you meet people from other countries, but actually makes you a better professional overall also.
All right, I'm going to go ahead and tell you to look at your survey, because there are some survey questions being posted, but that does not stop us from taking questions. I just wanted you to take a look at Is there any other questions in the room? Okay, I'm going to go to the second question up there we have handled. I'm going to do the first one. The second one was what professionals or specialists are missing in our panorama, and I think that's where we decided that generalists, we don't need specialists, we really need primary health care helping out here the most. So the top question, are there any trainings regarding health assessment of migrant children? We handled the third one. How can institution be helpful? This is a theme that you've got going, Ketil. Maybe you can elaborate what should be done from a regional perspective there. And let's see. Knowing the position, this is your third question. Knowing the position of the European Academy of Pediatrics, could one of the presenters reflect on this issue as it continues?
I'm pretty sure what the issue is age assessment.
Oh, okay.
Yeah.
Okay.
Because there is a paper by Sauer et al. From the European Academy of Pediatrics on that issue. And I could say something about it. It's a controversy in most European countries. We see that just about all countries in Scandinavia and on the continent use some kind of X-ray or magnetic imaging technique to assess age in the skeleton. We also know that as pediatricians, we know that these methods are very imprecise and aren't actually up to the task of saying who is over 18 and who is under 18. And because of that, the European Academy of Pediatrics, as well as the pediatric organizations in the UK, have very strongly opposed this use. But because I would say primarily for political reasons, these are used all over Europe.
Institutions, the role of institutions. Kettle, do you want to continue on that theme?
Once more.
Oops, can we flip back to the questions for just a moment?
Yeah.
Somebody was asking about the role of institutions.
In this, yeah. And in my field, which is care, there has been not much focus on institution. It's more the personal relations, and I think it's important to have both focus on how institutions are dealing with this care situation, and it's more than the relational aspects of care. It's also how institutions make good care institution. So and it has to do with it's had to do with power relations between children and caregivers, majority, minority. It has to do with being individual to care, not take a position of a category of children, which is quite common here, to make these just vulnerable without resources, without aspirations that can be possible to reach, and so on. And so it is important to highlight the system level of institutions, not only the relational, personal trust, for instance. So.
Any other questions in the room? I'm going to do one last round of questions from our online group here, if not. Okay, 2 more and then we're going to wrap up. What do you think about the importance of sexual reproductive health education promotion programs for migrant adolescents? Is it included in many programs or is it missing? Do you have an example of positive practice in caring of unaccompanied minors or unaccompanied adolescents and separated children? Did I get that acronym right? And would you please provide in writing the names and the sources referred to here by the authors of reports, books, etc.? Okay. I can say yes to the third one.
We can do, yeah.
Who wants to tackle 1 and 2? Sexual reproductive health.
Yeah, I could tackle that one.
Okay.
I think that it is actually a very important issue, and it's much broader than when we usually talk with adolescents about these issues, because we're talking about adolescents that come from very different circumstances and where sexuality in itself is not dealt with. It's not where adolescents are not at all supposed to be as sexually active as they actually are in Europe. And so we need to have in this education to have a lot of discussions about these things, because it can easily lead to misinterpretation in the relation to the other gender or the same gender when when they are in situations where they start to have sexual activities. So, I mean, this is for all of us a difficult subject. But if you come from another culture with a different background, it's really difficult. Yeah.
Anyone else want to add to that?
Yeah, a little bit, but maybe a bit different, like the female circumcision that we see sometimes in young children. I think, again, this same organization, Faros, has, in the Netherlands, they made a program also for health professionals to be aware of that, to be able to talk about it to the parents, but also see the risk for other family members if they visit other countries abroad. And for and I know in the public health services is also mentioned and discussed with the mothers.
I'm forgetting one question. Can you flip back to the questions for me? My aging brain is failing us at this point.
I also can't remember. So.
Yeah, there's the first one, no, second one. There it is.
Yeah.
Do you have an example of positive practice in caring of UASC, unaccompanied adolescents and separated children?
Yeah, there are many examples, but they are often descriptions and principles or policy documents. For instance, UN High Commissioner has made a best practice to unaccompanied minors, for instance. So there are more like principles and description. I don't have an immediately a good example of, but of course in Norway, trauma-informed care is very used in different institutions. So I think they are good principles. There are no, I don't know if there are any research on special practice because it's difficult to, of course, make research on such issue. But it's possible. But it's a challenge, of course.
All right. Any other comments from this table? I'm going to wrap up with one question, if not, and that's for each of you, and you get about 10 seconds to answer it. If you could give one piece of advice to policymakers on this issue, what would it be? Albertina, we'll start with you.
I think the most important thing is that we find each other, the different institutions, that we need each other, public health, the curative services, and that we work together in a chain of care around these children.
Anders? Don't look at me like that.
Yeah. For me, it would be to please honor the obligations you made by signing the Convention of the Child and provide equal access to healthcare and education for this group of children who really, really need it.
Ketil?
Of course, it has to do with how institution could be trustworthy. Do ask that question, and because then you have to look at what are the purpose of the institution, and it's very easy to forget this issue.
Thank you all
Thank
very
you.
much, and thank you for sticking to 10 seconds at the end there. That's going to wrap us for today. In case you didn't know, Dr. Anders Jøren has a report coming out with WHO this fall, and you can find that on, I'm certain, the Knowledge Hub for Health on Migration. Is that right, Joseph? Yes, that's right. Excellent. All right, so keep your eye there. As soon as it comes out, you will clearly grab it up. There's a lot of interest in that report, so hurry up. All right, thank you for joining us. This wraps this particular webinar on unaccompanied minors and children. Thank you.